And we'll start the webinar. Let's get started. That's great. So you notice that we'll get the questions being in the question and answer section. We'll not try to get them on the chat section. We'll keep the chat section for chat. We'll start the webinar. We'll start. Let's get started. That's great. So you notice that I just turned off my YouTube because the YouTube channel just echoes things that okay. So good evening, everybody. This is the 19th webinar from iBreastbook, and I can see that already we have 200 people online, which is great. This webinar is mainly about the European Board of Surgery Qualification Exams, and we have great speakers, and we have also great panelists. Also, we're not talking only about the exams, we're talking about academic vivas, how to read a paper. There's a couple of small videos about a couple of master's degrees and about the breastics event. So we have great speakers, including Linda from Sheffield, and we have also
Die Kinderfreunde weil Papa fast mitgebracht. Und da habe ich jetzt Flor, den Sausewind und für den Großen.
That's good. So we have three speakers. We have Linda Wild from Sheffield in the UK. She's going to talk about the academic viva and how to read the paper. Christos Markopoulos from Athens in Greece. He sent us a recorded talk. Unfortunately, Christos cannot be with us today. He's not feeling great. So we hope all goes well and he becomes much better in the next day or two. And we have Ibrahim Idhemovic from Ljubljana in Slovenia, who's going to talk about the surgical oncology exam. The usual suspects, and me and Ash are always online. It's great to see Ash again. And also it's lovely to see Bahadir again, who's going to tell us about the breastics 24. It's great to see Sergio Sandrucci, who Sergio is previous chair of the Education Training Committee and S1, one of the sarcoma surgeons in Turin. And it's great to see Sudan also with us, who's the coming chair for the Education Training Committee for ABS. And he's going to talk about the master's degree from University of East Anglia. When you have questions, please go and put it on the question and answer section. Don't put it on the chat section. All the speakers are either running the exams or examiners in the European board, so they'll be very helpful to guide you what to do when you want to sit the exam and how to do things. If the chat function is mainly for chatting, so feel free to use that, and we'll start the talks. So the first speaker is Ibrahim Idhemovic, and Ibrahim is going to talk us about the European Board of Surgery Qualification in Surgical Oncology. Ibrahim, the next 15-20 minutes are all yours.
Thank you very much, Yazan, for your kind invitation and introduction. Well, let me see, just to share the screen. Okay, so to select this one. And this one. Okay. Okay, fine. Thank you. So, ladies and gentlemen, dear colleagues, first of all, I would like to thank you to Yazan for his very kind invitation and for giving us the opportunity to say a few words about our exams and what we do in regard with this. So before I keep talking about the exam itself, I will let me see, this does not work, how to change these. Oh yes, everything is now different. So before I start talking about the exam, just a few words about the surgical oncology, because this term is not very much accepted and recognized in certain countries. So those who do not recognize this specialization, they say the surgery is one word and oncology is different second world, and these worlds simply cannot work together. But this is very wrong. Actually, this is a winning combination. The throw is just opposite. So because the times when the surgery alone was the main treatment has gone. And now there are many different treatments which combine surgery and other multimodal therapies, which help us and help patients to have the better outcome. So the surgical oncologist is actually a specialist much wider than just simple technician who performs the surgery. He must be very aware of the biology and natural history of the disease, and he must be fully aware of oncological principles of cancer surgery, respecting the compartments and biological planes, lymphadenectomies, and other important structures. And surgical oncologist is an important part of the multidisciplinary team when discussing about the cancer treatment. So the UMS means European Union of Medical Specialists, and it's the oldest medical organization in Europe. It's more than 60 years. And it is established to ensure the highest standards of medical care across Europe. Now over 40 countries are now included and 43 different medical specializations. And European Board of Surgery actually is one body within UMS who runs many exams in partnership with ESO, also this one about surgical oncology. And the aim of this exam actually to provide the evidence that the surgeon is good enough, is expert, and that he reached the level which is necessary and acceptable in all European countries. Our section of surgery includes many divisions, as you can see on your screen, which includes surgical oncology, breast surgery, and many others, if you can see here on the screen. And all of these divisions, they organize different exams in those areas. On the other hand, European Society of Surgical Oncology was established more than 40 years ago. And actually, it includes the wide spectrum of very experienced specialists from different areas in cancer treatment. And the main task of European Society of Surgical Oncology is education and spreading the knowledge. Of course, there are many other things, but the most important involvement of ESO is education and spreading the knowledge, improving quality of care and research. So ESO, I will show you later, is very deeply involved in organizing and this exam, because many people sitting in education and training committee in ESO actually are sitting at the same time at the division at UMS, and they actually care about the questions, and they care that everything is up to date and reach maximum possible quality. Global curriculum actually is a document provided and created jointly by European Society of Surgical Oncology and Society of Surgical Oncology. It means American Society of Surgical Oncology. These two associations are actually the biggest and most important associations in the world regarding the surgical oncology, and they analyzed the treatment outcomes in many countries, and they realized that there are huge differences between countries, and they set up a global curriculum in which they actually described what is the minimal level of standards in which every country, every institution must reach in order to afford to offer to patients good cancer treatment. And our exam actually is based on this curriculum, and of course, end of the curriculum of European Society of Surgical Oncology. So it is so much everything interconnected. So our exam is designed to test the surgeon has a sufficient level of knowledge in cancer surgery, and if successfully passed the exam, he is becoming a fellow of the European Board of Surgery. So the fellow of the European Board of Surgery in surgical oncology is actually indicator. It's a sign that that person is something more than just average surgeon, and it reflects ongoing important European standardizations. But not everybody can just like that approach to the exam. There are some criteria which we follow very strictly. First of all, candidates for the exam must be specialists. So residents, at least at this moment, they cannot sit the exam because we require certain experience from our candidates. So they must show us the certificate that they have completed the specialization or they completed the training, the surgical training. Then they must show that they must demonstrate that they spend some time in high quality surgical oncology centers. So there are, you can see on your screen, there are several conditions which must be met, any one of these. But you don't have, if you're interested, you don't have to write this down, because you can find this on a website at the UMS, so everything is actually there. But the key point is that the person who is coming to our exam must have certain experience in surgical oncology. Then eligibility criteria includes also a logbook. The certain surgical experience is also required, because to be a good surgeon and surgical oncologist, you must have certain number of operations performed. We cannot accept you, for example, as a rectal cancer surgeon if you operate one rectal cancer a year or even less. So you must upload your logbook in last 3 years to show us, to demonstrate what is your opus of surgery and how much and what did you do. And of course, letter of recommendation from your boss. So all these documents have to be uploaded. So you have to fill online form, filling all data which we need, such as personal data, education, and so on. Your CV, your photograph, certificate that you have completed surgical training, logbook, and letter of recommendations. Unfortunately, the exam is not free. We must cover our expenses. So for the eligibility assessment, which is the first phase of approaching of the exam, you must pay 250 euros. And then after that, all documents will be sent to the eligibility committee, who will assess whether you fulfill or no the criteria. And in case that you fulfill, then you will be asked to pay another 350 euros. It's an examination fee. Unfortunately, in case that the candidate is not selected, we cannot refund this money. And all payments must be made by PayPal. There is some literature, quite a lot, which is important and which candidate must study before approaching the exam. This is something from basic science. These two books, this list is updated in December 2020. So it's being updated every 2 or 3 years. Then 3 basic textbooks from surgical oncology. You can find it here. This is all on a website. Then there are some books and textbooks which are specific for specific sites, for the breast, pancreas, HBB, and so on. Then literature related to clinical oncology, palliative care. After that, online sources are actually very important, because everything which is new, which is freshly published, first appears on at some websites. So it is very good if candidates, and after you pass the exam, from time to time check these websites to see what is happening and what is new. And of course, you must be fully aware of significant clinical articles. But we will not your question and ask many articles, but there are some articles who actually change the strategy. They are so-called game changers, and you must be aware of these articles. So the whole exam consists of 2 parts. It's a written part with 60 questions. It takes 2 hours, and there are no penalties for wrong answer. So the principle is best of 5. It's also one answer is possible out of 5. And then oral part, which includes 2 sub-parts. It's a clinical part, 30 minutes in total, with 2 clinical cases, and academic part with 2 academic papers for discussion, also 30 minutes. We now offer this exam in 3 languages, in English, German, and Spanish. So if somebody doesn't feel very familiar with English, that he can apply for German or Spanish language. We are also discussing about French language, but this is not yet finished. So what is now included in our spectrum of question is breast, is melanoma, skin endocrine is second, is colorectal peritoneal surface malignancies, upper GI, HBP, sarcoma, and also general oncology. So all these areas are included in written exam. It is a little bit different in oral. I will explain later, but for the written exam, regardless of what is your subspecialization, you will have questions from these areas. So the exam is based online, and we did it, which means that actually it is paperless. Everything is run through the application on the internet, and there are no papers, nothing. But it is online, but it was also on site, which means that candidates visited our exam centers. We have 18 remote exam centers, and we use them and run them jointly with breast exam. And the breast exam group and surgical oncology group, they have exams at the same place, same time, simultaneously. But this modern technology provides us to run 2 or 3 different exams in different languages on the same place, which is very nice. So how does it look when you open your application? Something like this. Actually, you see there is a question in the upper part of your screen, and there are 5 answers. You just click on one of these, and that's it. You can go backward, forward as many times as you want until your time is out. So everything is very simple. Then we analyze the results, the questions, and everything else, and finally create the list of successful candidates based on what comes from computer. This online system practically eliminates the possibility of any mistake. So it is very safe, and we're sure that everything is correct, that everything is calculated properly. The pass mark of our written exam is different every year. It's being calculated using Enghoff referencing method, which means that I'm not now going to explain in details, but the base of this procedure is that the final pass mark depends on the complexity of the questions and not from the quality of the group of the students. Like, for example, it's percentiles based system. So we don't use that one, but we use this pass mark. It is different every year, depending on how complex questions are, but it is somewhere between 55 to 65%. If candidate pass oral exam, then he is invited to attend the oral. I said, if candidate pass written exam, he is invited to take the oral exam. And this, what is difference here? During the registration, you will be asked to specify actually 3 subspecializations from those 6 mentioned earlier. And then during the oral exam, you will be questioned only 2 of these, but we will not tell you which 2. So you must be prepared for all 3 of these. And so that is how it actually works. So the oral exam consists of 4 15-minute tasks, as I said earlier, 2 times 15 for clinical case and 2 times for a scientific paper. You see, the examiners, they work in pairs. So each of them will question you for 15 minutes. For example, for clinical cases, we can discuss, for example, a rectal cancer patient. We will see the history, some diagnostic details, and then we will show you this MRI, which you can see on the right screen. So this is locally advanced tumor, and we expect from you that you explain us what you see, to explain us where the circumflexural resection margin should be, and what to do in this specific case when actually the CRM is actually invaded, and how to treat this patient. Actually, you see that you must you must understand and read MRIs. So surgical oncologist must analyze the images by himself, of course, together with the radiologist, but you must plan your operation based on MRIs, based on images. And of course, 2 scientific papers. Papers are provided 2 hours before the exam, and candidates are allowed to have that paper during the exam. So they will read it before the exam, and then It will be very important papers published in distinguished journals like Lancet or New England or AJCO. So probably the most of papers for this exam are already seen by many of candidates, because the papers we use are really important papers. So during this part of exam, the focus is not on the content of the study or the disease described, but the focus is on the design of the study. You must describe and understand what is the purpose of the study, what kind of study. Was it phase 2, phase 3? What does results say? What do results say? And things like that. We must analyze for discussion, and we would like to hear your comments. Are you happy with the discussion? Would you change anything? Do you think that study is offering the answer which is questioned at the beginning, and things like that? And this is the best part of the exam. Of course, successful candidates will, there is a small ceremony at the end, and the successful candidates they receive the certificate, and we take photographs, as you see always. They have many photographs with candidates and joined like this, and that is it. So this is for short presentation, short description, and thank you very much for your attention. I will be happy to take any questions.
That's great, Ibrahim. Many thanks for that. And we have a few questions on the question and answer section that might be relevant. So we will take the questions at the end after all the talks. But do you mind, Ibrahim, having a look at those questions, because some of them are about eligibility criteria and things like that, just to clarify things. Okay. And when you feel that you want to mention it live, when we come to the question and answer section, we'll do that.
Okay.
Now, the second talk is by Prof. Christos Markopoulos, and unfortunately, he cannot join us because he's not feeling great today, but he has sent us the presentation a few days ago, the talk about the European Board of Breast Surgery. So I'll play that from my screen, if that's okay with everybody.
Hello, dear colleagues. In the following minutes, I'll give you some information about UEMS and the Division of Breast Surgery. And then I will present you the European Board of Surgery qualification exam in breast surgery. We all know that breast cancer situation is variable among European Union countries. We have the highest incidence rate of breast cancer in Northern and Western European Union countries, and the highest death rate in Eastern European Union countries. Of course, higher rates of new breast cancer cases per year are most likely due to different lifestyles and socioeconomic status, but clearly differences in disease outcome are reflecting inequalities in breast care services provided across Europe. There are multiple parameters to achieve a favorable disease outcome in country level, such as the existence of national screening programs for early diagnosis, existence of national programs for the education and training of breast specialists, including breast surgeons, and breast care provided in organized breast units where European practice guidelines are adopted, and of course, adequate funding of national health system and research as well. So, in other words, in order to provide high quality breast care, you need a breast surgeon who is well educated and properly trained, working in the proper environment of a breast unit which is properly organized. Both need accreditation and quality control as well. And it is here, in regards to the education and training of a breast surgeon of our era, where the UEMS, European Board of Surgery Qualifications in Breast Surgery, is involved. Let me give you some information about UEMS. The European Union of Medical Specialties was founded in 1958. It has 40 countries as members and represents 43 specialty sections. Overall, UEMS represents over 1.6 million medical specialists, and UEMS has a main scope to set standards for high-quality healthcare practice. It is divided in sections, among which is the section of surgery and European Board of Surgery, and each section is divided in divisions, among which is the breast surgery division. The division of breast surgery has an executive committee consisting of colleagues from 9 to 10 European countries, showing a very good representation of European countries. The main objective of the division is to promote and support the highest standard of care in breast surgery in Europe through high quality education, training, and accreditation. For this, the division has a curriculum and a syllabus. The knowledge of the breast surgeon is evaluated and certified by the European Board of Surgery Qualifications, or otherwise known as EBSQ examination in breast surgery, which is organized by the division. There are 3 phases in this exam. Let me explain now the whole format of the exam and how it will run. The first phase is the eligibility assessment of the candidate and is totally online. Second phase is the multi-choice question examination, which is usually end of June. And the third phase is the oral examination, which is usually during the last weekend in September. Candidates can submit their applications through our web system, where you can also find a list of the eligibility criteria if they want to take the exam. The eligibility assessment is the whole online, is a total online process via the website, and includes review of CV, logbook of operations, and certificates, because we need a medical degree and a specialty, or in other countries, an equivalent like in UK, or proof of completion of 5 years of surgical training. Eligibility assessment approval online results usually with 1 week. Applications start usually 1st of January each year, and deadline for application is usually end of April. What is included in the eligibility criteria? The applicant must hold the current license to practice as a surgeon, general surgeon, plastic surgeon, or gynecologist, because in some countries, gynecologists are doing breast surgery. He or she has to demonstrate that work for 1 year at least in a breast surgery unit with at least 150 new primary breast cancer cases per year, attended at least 1 national or international training course in breast surgery, and has attended at least 1 well-recognized International Congress of Breast Disease during the last 3 years. The applicant should also present a signed logbook for breast surgery within the application, and also show evidence that he has published either 1 paper or book chapter of breast disease, or presented 1 paper, oral or poster during the Congress. logbook required. The applicant has to prove that at least performed 40 operations of benign or borderline lesions, 100 full axillary lymph node dissections or sentinel lymph node biopsies, including at least 30 full axillary lymph node dissections and at least 30 sentinel lymph node biopsies, 100 breast cancer operations during the last 2 years, and observed or assisted at least 10 immediate and delayed total breast reconstructions using both implant and autologous tissues. The standard of the examination is that of a junior consultant breast surgeon, but requires knowledge of reconstruction and oncoplastic and the latest breast research as well. There is a textbook, you can see it here, which is the official textbook for the exam. And there is a syllabus which is available on the website of the division to download. The knowledge needed to sit the exam includes a number of issues, starting from basic physiology, surgical anatomy, clinical assessment of breast conditions, and goes further to locally advanced breast disease, treatments, psychosocial support and follow-up, and also includes research and evidence-based medicine data, knowledge data, and furthermore, the quality assurance, how could be performed in diagnosis and treatment of breast disease. Also, knowledge and special skills on special issues is required, such as anesthesia and perioperative care or post-operative complications, and breast cancer in special parts of the population, young women, elderly, male breast cancer, and of course, knowledge of the current research and evidence-based medicine. The exam has two parts. Part A is the written exam, which is totally web-based, and Part B, which is the oral exam, which includes discussion of 2 clinical cases and a review of a scientific paper on breast surgery. For the web-based written exams, in the past we used to have centers in multiple European countries. However, following the experience we have with COVID, now it is completely web-based, and you can take it from your personal PC in the comfort of your home. The only thing which is required is a strong internet connection and latest update version of your browser. A few days before the exam, you receive by email the login details in the platform of the exam, username and password. And when you enter the exam, you will be asked to show an identification card, so your proctor will verify your identity. The exam opens at set time across all time zones, and mind you, there is a continuous supervision of proctors in your exam room, and also we use e-methods to avoid cheating by using and supervising through the camera of your PC. The exam consists of 50 multi-choice questions, and the total time allocated is 120 minutes. You can scroll between questions back and forward, mark as unsure if you wish to be reminded to go back before you finish. Usually, for the answers, you have 5 options. Only one is correct, and it is followed the best of 5 principle. There is no negative scoring for wrong answers. A few times, questions include clinical photographs and also imaging. The pass rate is variable. It's usually at the area of 60%, but each time is calculated using an international standard setting procedure, the Ancop scoring, which means that all the questions are reviewed by most of the executive committee members and some examiners. Very easy or very difficult questions are excluded, and then they are all scored by the reviewers. So we reach the final bank of the 50 questions each year and the passing score. The results are sent by email approximately within 1 week, usually sooner in a couple of days, and, which is very important, only if the written exam, the multiple choice questions exam, is passed, only then you can progress to the oral exam, which is the second part of the examination. The oral exam, preferably and up to date, was face-to-face. However, you all know the difficulties we have with traveling due to COVID situation, and for this year will be also take place through computers, will be totally web-based, virtual. Hopefully, from next year, we'll go back to a face-to-face exam, which we believe is more suitable for an oral examination. It includes discussion of 2 clinical cases, 30 minutes for each one of them, and a review of a scientific paper on breast cells. The paper is given to all candidates at least 48 hours before the exam, so they will have enough time to read the paper, understand it, and respond to the examiner's questions. In both clinical cases and the academic paper, there are usually 10 questions, and we also have 2 examiners who are scoring independently. The scoring system, you take 2 points, full points, if you give the expected answer, and it is also effectively supported. You take 1 point if you show knowledge of the subject, but your answer is somehow different from international guidelines. However, it must be reasonable and you must be able to support it well. And you don't get any passing points if you give a completely wrong answer, which is different to international guidelines, and you show no knowledge of the subject in discussion. So the oral clinical exam is very much like a mock MDT discussing an interesting case with a senior colleague. Of course, it may include the interpretation of imaging and clinical photographs as well. The academic paper is a 30-minute discussion about a recent academic paper, and we focus on methodological quality and study design, and partially on the clinical impact and the interpretation of the data found in this paper. For example, previous papers have included the Z11 trial and the Taylor X study. Final results after the oral exam are given on the same day, and usually overall the pass rate for the EBSQ exam is 70 to 75% for the multiple choice questions and 80 to 85% for the oral, among those who already have passed the MCQ exam. Certificates and prizes are given in person the same day at the end of the exam. What do you get? You get the certificate showing that you passed the exam and you are able to use the title Fellow of the European Board of Surgery, PEPS. We take a nice photo with all successful candidates holding the diploma, which is published in our newsletter along with the list of the successful candidates. And also your name is added in our website in the list of fellows of the European Board of Surgery in breast surgery. How much does it cost? The total cost is 700 euros. You have to pay in advance 150 for the eligibility check along with your application, then 250 to sit the written exam, and if you pass and proceed to the oral exam, you have to pay 300 which is euros, which is the cost for the oral exam. If you fail one or other part, you can retake it for 250 euros the following year. However, if you fail twice any part, then you have to wait 2 years to try again, and you have to take again both written and oral exam. When is the next sitting? Applications for the written exam in 2022 will be possible through the division website from 1st of January until 30th of April. The written exam is usually last Friday in June. The written exam will be totally virtual. As I said before, you can sit the exam from your home personal computer. The oral exam will take place hopefully face-to-face in Athens, or if we still have problems with the COVID virus, then will be hybrid the last weekend in September 2022. However, the dates will be confirmed on our website. I would like to thank you for your attention, and I hope I'll see you in the next EBSQ exam in breast surgery. Thank you.
That's great. Many thanks, Christos, for sharing that, and hopefully he'll be feeling much better. I see that there's some comments that the voice quality is not great. The voice is slightly muffled. I will try to tidy up the voice a bit and share the same talk again on the YouTube channel if you want to listen to it again. There's lots of questions on the question and answer section that we will go through at the end. There's lots of comments about the fellowships and the international medical graduates. And this is something that it's really dependent on the center. It's not dependent on the exam. So we will talk about that. And it's great to have Ash here because Ash takes lots of fellows in Guys. He has a big center there. I'm not sure if Sue also does take some fellows, and Linda. Now the third talk before we go for the other recorded talks is by Prof. Linda Wild. And if Linda has been always very active in BASO, which is the British Society for Surgical Oncology, in ESSO, the European Society of Surgical Oncology, also in the ABS, which is the Association of Breast Surgery, has been very active in all the exams for the surgical oncology and the breast surgery exam. In fact, most of the preparation books that you read for the exams, she's usually one of the main authors and the editors. And we noticed that in some of the exams, people fail more on the how to read the paper, and there are some simple things, especially for certain people coming from certain part of the world, that they can simply correct on by knowing how to read their paper correctly. And this is what Linda is going to talk about now, about the academic viva and how to read the paper, which is relevant for both exams, the European Society of Surgical Oncology for the Surgical Oncology exam and the breast surgery exam. And just a little comment, it's great to see that there is more than 400 people online for a non-technical webinar. That's a very good number for a webinar that's not talking about operations and techniques. Many thanks for everybody that is logged in. Linda, the next 15-20 minutes are all yours.
Right. Hopefully you can see that now and you can hear me. So thank you all for listening in. I am going to talk about the academic viva, which is relevant to both exams. I do have a conflict of interest in that I am interested in research, and so I'm probably biased towards this, but I have no financial conflict of interest. So you've already heard from Christos about the format of the breast exam. So there's an eligibility assessment, there's a written exam in an MCQ format, and there is an oral exam which has both clinical scenarios and also an academic paper station. I'm afraid to say that all of these parts of the exam have some component related to research. So for the eligibility criteria, we expect that you have published either a paper or a book chapter on breast disease or presented an oral or poster presentation. So we expect you to have had some involvement in either collecting data or analysing data or doing some research before you're able to sit the exam. The MCQ, whilst most of the questions on the MCQ relate to clinical problem solving, there may be some requirement to know a little bit about some of the key papers. And so every year, one or two of the questions will be asking about a particular research project. It will usually be something very well known like Z11 or something of similar sort of repute, but there's always at least one question related to this. And then for the oral exam itself, as mentioned, 2 of your exam stations, so 2 half-hour sessions, are clinical case scenarios, and then the academic paper itself is again a 30-minute session with 2 examiners. The oral exam clinical scenarios may also have some component related to research, and this is because we may ask you about why you manage a patient in a certain way. Why, for example, would you manage a positive sentinel node in a particular way? But we might ask you to tell us which trial showed that that was the best way to manage it. So we might ask you about Z11 or Amoros to justify your decision to clear or not to clear an axilla, for example, after a positive sentinel node. So the actual viva itself, you will be sent a recent academic paper, usually from within the last few years, and it's usually something that's been fairly high profile. You get it 48 hours before the exam, so use that time wisely. The questions that we ask are usually fairly well structured, and to a degree you should be able to predict the sort of questions that you're going to ask. And you can prepare for this ahead of the actual exam by joining a regular journal club, maybe asking your boss to send you some papers that you could perhaps read and then discuss with them. And you can also get some reasonably readable books about trial design and statistics. As mentioned, previous papers have included Z11 and Taylor X, and so they're all fairly high profile papers that we tend to choose. Don't panic. You've got 48 hours to read the paper, which should be plenty of time to think about it, to do some background reading, to look things up in a book about statistics. So we don't expect you to know every statistical test that's ever been developed and when it's used and what the faults are in it. So you've got time to do your homework before the viva. You can make notes and you can take those notes with you into the exam, but you can't take textbooks in with you. And the examiners aren't looking to see if you're the next professor of breast surgery, but we do expect to see that you've made a reasonable stab at understanding the paper and its flaws and how it might impact on your clinical practice. So it should be something that everybody can do well at. So I'm going to just spend a few minutes now talking about why we think it's important that there's so much sort of content in the exam related to research and publications. And that's because we expect good quality clinicians to practice evidence-based medicine. And that means not only using your clinical experience and guidelines, but also keeping an eye on the latest research that's out there, and being able to critique it and decide whether the time is right for that research to influence your practice. Okay. And why is this vital? And I think a very good example relates to breast surgery. So as we all know, axillary node clearance was the norm in breast surgery for all women for about 150 years, whether or not the nodes were involved. And as we all know, only 40% of women have involved nodes when they have breast cancer, which means that using axillary clearance for everyone, 60% of women would have had no axillary involvement. And I remember when I was a junior trainee in breast surgery in the 1990s that we used to clear every axilla. And it was always disappointing to me when those nodes came back clear and I felt I'd done an operation that didn't need to be done. At the time, I was a junior and I used to do what my boss told me, and I knew no better. But actually people did know better, even in the 1990s, because in the late 1980s, this trial, the NSABP-B04 and another trial out of Italy had published their 10-year results showing that there was no difference in survival or local recurrence or regional recurrence rates, regardless of whether you cleared the axilla, irradiated the axilla, or indeed did nothing to the axilla if the axilla was clinically negative before you started your surgery. This data was published again at 25-year follow-up, which reinforced the findings. And it was only really then that people started to take notice. And of course, now we know, and we've had other trials that have reinforced this, that lymphedema rates are lower if you don't clear the axilla, and that radiotherapy and no axillary surgery are much better for lymphedema rates. And of course, we now know that sentinel node biopsy is very accurate, sensitive and specific for staging the axilla and associated with much lower morbidity. So this is a very good example of research in practice and how it's changed what we do for the better and improves lives globally. So when we look at research, there's something called the hierarchy of evidence. And this is really a way of research on how it's and how much take face value. Review and meta-analysis trials. Randomized trials are just below that. Really, randomized trial or and so sometimes risk of bias. So go down this pyramid means the findings may be wrong. Liability of the
I think there is an issue with the internet with Linda because the voice is gone and I think the presentation stopped. I was worried that it's my internet. So as you notice that you are a co-host suddenly now, just in case my internet disconnects and the webinar goes on. So what we'll do is Linda is disconnected. Hopefully she'll be able to rejoin and then continue with her talk. But until she rejoins, there's 2 or 3 videos that I want to share, if that's okay. And the first video is about the masters in microsurgery, and also they have another masters in breast surgery oncology, which is from Barcelona, from the European School of Reconstructive Microsurgery. This is only a couple of minutes, so hopefully that will be all okay for you. So it's a great program. It's worth having a look at if people come from plastic surgery background and want to do microsurgery, but also they have a program in breast cancer surgery. But the other great program, which I'm privileged to be one of the tutors on, is the University of East Anglia. And they don't only have oncoplastic breast surgery, they have lots of other programs. So this is a short video from University of East Anglia, and it's great to have Sue down with us today, and Sue can answer questions in relation to that.
In 2010, the University of East Anglia developed the first blended e-learning oncoplastic breast surgery course with help from members of the Royal College of Surgeons and ABS. The course won a Gold Award for Best Blended E-Learning Programme and is still the highest qualification in oncoplastic breast surgery in the UK. The approach led the medical school to develop a range of postgraduate courses, attracting students from over 40 countries. Our approach to learning has remained the same to this day, to achieve the maximum learning gains, in particular around critical thinking, using the most flexible online delivery to meet the demands of a modern healthcare setting. Our postgraduate courses are all modular. This enables students to decide if they want to study for an individual module or build towards a formal academic qualification, such as a postgraduate certificate, diploma, or where available, a master's. All modules are taught at University Level 7, regardless of whether a student undertakes a university assessment or CPD route. All specialist surgical students study together for the duration, diploma, or where available, a master's. All modules are taught at University Level 7, regardless of whether a student undertakes a university assessment or CPD route. All specialist surgical students study together for the duration, forming a vibrant online learning community, and once a course is completed, often leads to valuable professional contacts. Our master's level courses generally last 3 years, studied part-time. As a guide, each module requires between 5 to 10 hours per week of study, including background reading. Students will not normally be expected to log on at set times, since the discussion fora are accessible 24/7, which is how they thrive and grow through contributions made by enrolled students from across the globe at any time of day or night. Our programs employ a mix of learning tools, at the heart of which is an immersive problem-based learning process. For each scenario, real cases are discussed in depth by the online group. Students bring background reading, their own knowledge, and personal experience together in a collaborative, investigative way, with tutor guidance to arrive at a point of critical understanding around surgery or medical cases they are likely to see in practice. This is combined with formative tests, where students check that they have met the expected learning outcomes. Students also take a deeper look at expert reasoning with script concordance tests that can enable them to compare their own reasoning against that of the tutors. Finally, they must bring all of this together at the end of each topic through the submission of their own individual treatment plan for the scenario. Once submitted, the tutor's own suggested treatment plan is released to enable the student to compare and contrast. The University of East Anglia has been working with renowned members of the leading UK professional surgical associations to build award-winning specialist courses. Back in 2010, the founders of these courses recognized the value of blended online learning for busy surgeons and medical specialists to enable them to acquire essential medical knowledge and consultant-level critical thinking while working within busy clinical settings. We have never lost sight of the original reasons for creating these uniquely tailored courses to raise standards in these specialist surgical fields. This is why so many of the top international names, including many pioneers in surgery, have remained dedicated to our teaching faculty to this day. If you would like to find out more about these courses or would like to apply right now, then please see the following links. We take students every September, January, and May. Please take note of the application deadlines. Although we do try to be as flexible as we can't always guarantee late applications will be accepted, in which case they would be considered for the following admission point.
And that's great. And I think Linda is still struggling to log in. So if she managed to log in, that's great. If she doesn't manage to log in, then we'll go ahead with the question and answer section. But before we go to that, there's lots of questions there. And please keep on putting the questions on the question and answer section, not on the chat section. Now, it's great to have Bahadir. And Bahadir has been the the mind behind this Breastix 24-hour webinar, which is going to happen next weekend. So we've managed to do a little video ourselves about this, for you to know about that. So it's great to have Bahadir also online. If you want to know a bit more, you can ask Bahadir about this.
I would like to invite you all to a 24-hour continuous online sponsor-free training event called Breastix 24 Hours. Breastix 24 Hours is a project in which 8 regional societies or academies come together and collaborate as main partners. Among these societies, there are Greta, iBreastbook, Oncoplastic Academy, Brazil, American Society of Breast Surgeons of Australia and New Zealand, Chinese Breast Cancer Society, Association of Breast Surgeons of India, and Senator.
In Breastix 24, you'll have lectures, you'll have tutorials, you'll have panel discussions, you'll have MDTs, and you'll have video sessions for technical teaching. This will be delivered by breast surgeons, plastic surgeons, pathologists, oncologists, radiologists, and more. We'll have more than 100 speakers and panelists on the day.
So here in this event, each main partner will do his part in 3-hour block sessions. We will follow the daylight, starting from Central Europe, then go to UK, then to South America, then to North America. Then we will cross the Pacific and come to New Zealand and Australia, then to China, then to India, and finally to Eastern Europe and Western Asia, and we will finish the program.
This will be on the 25th and 26th of September, when day and night are equal around the world. We will start at 1:00 p.m. GMT time and finish the following day after 24 hours. Welcome to Breastix 24 Hours. We are looking forward to seeing you online.
So please go on the website, register, it's for free. We already have more than 1,000 registrations. I think we reached 1,500 registrations, if I'm not mistaken, Bahadir. And
yeah, so far we have more than 1,500 registrations from 107 countries. So that's good for now. So we still have one more week to go.
We have a very heavy week to go, and we'll hopefully we'll double that. And it's great to see you, Linda, again. So do you want to finish your talk, Linda?
Yes, I'm very sorry about that. I'm just going to screen share again. So just bear with me for a second. Here we go. If I can get screen share to work. Here we go. And okay, so apologies for leaving you all there. So I just really wanted to give an example of how you can run into problems with research if you don't understand some of the pitfalls that limit the quality of your data or your analysis. And a good example is how we've looked at whether or not removal of the primary when a woman has metastatic breast cancer at the time of diagnosis. And there have been lots of research papers looking at this. Some of them are summarized here. Most of them are observational studies, so cohort studies, apart from 3 which have been highlighted, which are randomized trials. And I'm just going to go through a couple of examples of how trials can trip people up. So the problem with observational studies rather than randomized trials is that they are more subject to bias because people tend to be allocated to a treatment rather than based on their characteristics or their disease characteristics rather than at random. And so you get differences in the populations that have been treated in different ways. Now, you can overcome this to a degree by using propensity score matching, but this is never perfect. And so if we look at this particular question, should people with metastatic disease have their primary removed? This is a French study, which is an observational study, and it looked at lots of women, so 2,000 women who had had surgery or no surgery for metastatic breast cancer. They didn't do any matching. And what they found was that there was a benefit to having surgery, which was quite striking and statistically significant. So based on this, if this was the only paper you read, you would think that all women with metastatic breast cancer should have their primary removed and have surgery. Now, what you did see, if you critically read this paper, was that women in the surgery group were quite different to those in the non-surgery group. They had fewer areas where metastatic disease was present, they had more treatment, more likely to have radiotherapy, and they were younger and fitter. Now, therefore, the trial findings were actually very biased, and you can't really rely on them. Now, you can adjust for those sorts of things, and this study, which was based on American data, again, an observational study looking at this, and it had 30,000 women included, so a very big study, which sounds very impressive. Half of those women had had surgery and the other half had not. The problem was, although they found in favour of surgery, again, there was a lot of bias because they hadn't matched the metastatic burden or disease location or whether the women had had systemic therapy. So the women who'd had surgery were quite a different population still, despite their attempt at matching, which meant that the results couldn't be relied on. Now, if you look at the randomized trials, and this is the data from that, so you can see here the finding of that particular study, even with its propensity score matching, was that surgery gave better survival. Now, if you look at the randomized trials, of which there have been a few now, these have found that there is no benefit to doing surgery. This is an American study, not a very large study, but adequately powered, and they found that the survival was not better if you had surgery. Local control was slightly better, but there wasn't much in it, but quality of life was worse. And this was a similar finding to the Tata trial, which was done in India. And so this is why you have to be very critical when you're reviewing data from trials, and you have to understand what you're looking at and where those pitfalls and biases may be found. So this is why it's important that you understand how to critique a paper, and that's why it's in the exam. So the next part of this presentation is going to be how to do this, okay? And I think probably the single most important thing is to read a really nice little book. So it's a very small book. This is it here. This is an older version, which is my version from when I was doing exams 20 odd years ago. There are updated versions of it now. It's easy to read, very friendly, doesn't have long words in it, and it really nicely explains all about research limitations and how to critique a paper. So I would strongly encourage you to get a copy of this. The other thing to do is start reading papers, find out some good papers from colleagues, discuss them with colleagues, attend conferences where they have sessions where you can listen to research being critiqued. Journal clubs are really good if you've got one locally, or an online journal club where you can share the process of critiquing papers with others, and you also learn about the research that's been done. And if you can, get involved in some research, even if it's something fairly simple. It will just make you more appreciative of how difficult research can be and help you to understand the limitations. So key questions for when critiquing a paper. One of the first ones that gives you a good idea of whether it's any good or not is where's it been published. If it's in the Lancet, it's probably a good paper, not always, but usually, because the bigger a journal in terms of its impact factor, the better the editorial review policy. And so they'll have lots of experts critiquing the paper before it gets into print. Is there conflict of interest? This is something that I think is very important, especially with big pharmaceutical companies funding trials. And sometimes pharma companies fund trials and have editorial control over the content. And that's important that you look out for that. So that's an important issue for you to be aware of, because if a trial finds in favour of something and the authors have got shares in that company, then that's a big source of potential bias. One of the first things to do when you've got the paper is just to write your own mental summary of it. And there are some things that you can do. Think of PICO, which is a population intervention, whether there was any control measures, and what outcomes were looked at. And that will give you a good flavour of what the paper's all about. And you can write that usually in a couple of sentences. And usually one of the first questions in this Viva is, just tell us about this paper. What have they done? What have they looked at? One of the main issues to look at is the population appropriate? So have they studied a representative sample of people? So, for example, we know that a lot of papers looking at chemotherapy and surgery will tend to recruit younger, fitter patients, perhaps than we would normally see in our routine practice. And so that's important. Is there a bias in terms of the population that would make them non-representative of the sort of patients that you would see in your own practice? And also, is there any allocation bias? So if you're comparing two groups, are those populations the same? You can usually find out about this by looking for a demographic table. So all papers will have a demographic table which shows you the characteristics of the patients in the different allocation groups. And so one of the key things that you should do when you start looking at papers is to look at that table. It's probably one of the most important tables in a paper, and see if your groups are comparable. Another factor that you will sometimes see critiqued is whether the study was adequately powered. Was it big enough to show the difference of the size that you're likely to see when you're comparing two different treatments? There'll often be a specific section in the statistics and analysis section about a preemptive power calculation, where they decide before the study is run how many patients they need to recruit for that study to have a chance of finding a statistically significant result. If they don't have that, then that should be picked up and as a criticism of the paper. Another thing that papers sometimes do is they don't pre-plan their analysis, and they recruit a group of patients, and then they start looking at everything and anything they can to try and find anything that's significant. And they may also then refine their analysis by looking only at certain subgroups. Now, if that wasn't set out in advance, that may mean that they've sort of basically mined the data, so they'll find something worth looking at, even though the overall findings aren't significant. And that, again, is a source of bias. We sometimes give systematic reviews as the paper that you're to critique, and there are some fairly good ways of critiquing systematic reviews. You need to look at how detailed they were in reporting what papers they excluded. So you would think in a systematic review where you report on every single paper that's looked at relevant subject to your topic, but it's very easy to exclude papers that you don't like. And so there should be a detailed chart reporting which papers they've excluded from analysis and why. There's a very good example of this with a review of screening quite a few years ago now, where they excluded every single randomized trial except one because they said it didn't meet quality standards. And the only paper that they accepted was one that had found against screening. And that paper was quite heavily criticised at the time. You'll also see in systematic reviews, they tend to show things like forest plots, which are a good way of describing multiple different study cohorts. And forest plots are very nice things for us to ask questions about. So we've had a few systematic reviews as our papers, and we will often ask you to talk through what does this forest plot mean. This is an example of a cohort study where you can see that there is a difference in the allocation of patients to two different treatments. So this is older women with breast cancer, women who had surgery, women who had endocrine therapy alone because they were thought to be too frail. And if you look at this data, you can see that women who've had surgery do a lot better than women who have endocrine therapy alone. But if you look at the age profile of the women, women who had endocrine therapy alone are a lot older and less fit and more comorbid than the women who had surgery, which means that you'll inevitably get a difference in survival. Now, this particular paper then did what's called propensity score matching to correct for that. And so that would be something which you would be able to spot as a fault in a paper when you are critiquing it. I think I've already talked a little bit about population adequacy, and this just gives a little bit more detail about how you do a power calculation. So if you go to the methods section of the paper, you should be able to see whether or not they've preset the sample size before they ran the study. And the way that you do that is you look at previously published data and say, okay, well, we're expecting this particular drug to have about a 10% beneficial effect on blood pressure, for example. You can then build that into your power calculation and say, okay, if we're looking for about a 10% difference, we know that we will need 200 patients to find a statistically significant difference between drug A and drug B. And there are formulas that you can use to calculate this. You don't need to know the formula, but you need to understand a little bit about the process when you're reading the paper to see that they've actually done this. Statistics. Everyone is terrified of statistics and nobody understands statistics. And I'll be honest with you, a lot of statistics go way over here for me too. And you don't have to know a huge amount of detail. Firstly, for this exam, you've got time to look things up. So you can go and look up in a statistics or Google it and find out what a particular statistical test is used for. There are some things that are fairly sort of obvious though. So for example, you should know the difference between means and medians and modes when you're describing an average value and when you should use those. You should know what P is less than 0.05 means. So that's something that we've asked in the past. And then there are some very basic statistics such as chi-squared and t-tests, where again, we may ask about those and we may ask you to explain what a Kaplan-Meier survival curve is, for example, or what error bars means or what standard deviation means. So if you see these in the paper, look them up, find out what they mean, and practice answering a question that might perhaps ask some of those questions. Again, you might be asked to interpret the data. So we might take you to the results section of the paper and show you one of the figures and say, well, what does this mean? What does this error bar indicate? What does this p-value mean at the bottom of this chart? What is a forest plot? So all of these things will be fair game when we're asking you to talk about the paper. And then the last thing is to ask you to draw your conclusions. Do you think the results that this paper has found are valid? Do you trust them? Is it something that would make you change your practice, or would you want to wait until there was more evidence before you did that? Another thing to look at critically is, have the authors of this paper overinterpreted their data? I've seen many papers where the findings are at best borderline, and yet when you read their conclusions and their abstract, they make out as if the findings are really world-beating and practice-changing. So do you actually agree with their interpretation of the results based on your critical evaluation of the paper? There are some easy wins. A lot of good papers have a whole section devoted to criticizing the paper itself. Read it. And then if you're asked to critique the paper, then you can parrot those back to us. So that's really all I have to say. Obviously, there's loads that you could talk about the different quality standards of different types of research. But because you have 48 hours with this paper, you've got time to do your homework. And so you should stand a good chance of being able to do really well in this paper and in this oral station. And we think this is important. We think this should run through everything that you do. And so I would encourage you to get involved with doing this and to do this as part of your normal practice and not just do this for your exam. So thank you very much, and sorry about the technical glitch partway through.
Many thanks for the great talk, Linda, and many thanks for being part of this. Now we'll go to the questions and the discussion, and there's lots of questions online. May I start with Sergio with Prof. Sandrucci. There is a comment on a question about from Arshudullah Khan about surgical oncology exam, and are there lots of basic science questions rather than clinical surgical questions, and why do we need basic science questions in those types of exams? Do you have any comment about that, Sergio?
Yes, there was a great debate inside ESSO about the meaning of the term surgical oncologist, because the great discussion is dealing with the difference between the surgical oncologist per se or the organ-based surgical oncologist. So the colleague is right talking about the organ-based specialist. But if you want to name yourself a surgical oncologist, you have to be an oncologist. So you have to know your enemy. You have to know the disease you are treating. So you have to, I don't know, I don't mean to know deeply, but to know how to treat the disease, not only with your specialty, because you have to keep in mind that you deal cancers within the within MDTs. So you have to discuss with your colleagues. When we deal a clinical case within MDT, we are challenging ourselves with our limits. My limit as a surgeon, the limit of the oncologist as a professional, but I have to know what the oncologist can offer. We have to keep our leadership in the MDTs by knowing what are the treatments, and not only by obeying to orders of other specialists, because we are very good surgeons, but we are have not very clear ideas about the biology. You know very well that there are cancers who don't need surgical treatments upfront, other who need, but who decides it? If you don't know the biology and the possibility of the best care available.
That's good. There's a little comment from Ash. He might need to leave early, so I need to stop making him a co-host so that if he leaves, he doesn't close the whole webinar. There's a couple of comments about specifics about the next exam, the 27th of November, which is the breast surgery exam. And there is specifics about the surgical oncology exam. If there's any changes in the exam, you will be notified by the exam team. It's not this platform that will tell you if the exam will go ahead or not. I know that we have the people that lead the exams here, but I don't think it's a correct platform to comment on that. You should hear from the admin team soon. Now, there's lots of asked questions before you run away, Ash, about international medical graduates and about fellowships and things like that. And I know that I had a lovely lady who's a fellow from Saudi that has gone to Guys and join your team. And I think you have lots of fellows in Guys and you accommodate lots of people. Is there any comments about the fellowships that you can get? Because I know that you have an ESSO fellowship, you have some fellowships that are not ESSO fellowships, and you're well connected to everywhere in the world. Any comments about that, Ash?
Yeah, you're right. We do get a lot of applications for fellowships. We do have an ESSO and a BRESSO fellowship, and we also are part of the International Surgical Training Program. So we have candidates from third world countries, middle income countries, as well as from Saudi Arabia, like you said. So I think when they apply for fellowships, what they need to be wary of is two things. One is GMC, which is mandatory if you want to do any hands-on work in the UK. So you should be eligible for GMC. And the second thing is we cannot assist with visas. So you have to tick all the boxes for the visas. We can give you the sponsorship letter and everything else to assist with that process. But it is important that they understand that the visa process is assisted by us, but is not done by us. So these two things, contacting the GMC before coming to us and making sure that they're eligible for visas, because after Brexit, there are lots of things that have changed. In the COVID era, the visas were taking forever, because I know that we have international fellows and it took them 6 months to get their visas extended. The second most important thing is, are they self-funded? Because, like the candidate you sent us, she's lovely, Huda, and she's working with us now for almost 3 weeks. she's self-funded. So certain governments like Kuwait, Qatar, Saudi Arabia, they will fund their surgeons to go to other centers and learn surgery, especially oncoplastic breast surgery. So self-funded and eligible candidates, they're easier to get into the system because, as everyone knows, otherwise in the UK, you have to make a business case and you have to convince your managers that you need a fellow and the training and everything else. And the most important thing is, I think the international trainees need to be mindful of the fact that there are already in big tertiary referral centers or academic centers like Linda's, they will already have, like Sue has, you will have trainees that are part of the regional deanery training program or specialist registrars. So you are then competing with them because we have an obligation to provide that level of training and tick all the boxes in the logbook to those trainees. So you will be an important part of the training curriculum, but you will always be, or your needs will always come second to that person's need because it is an obligation for us to fulfill that. We don't necessarily bias or choose and give them more work, but I think realistic expectations, because when they come to a big center, they expect everything to be oncoplastic breast surgery. Now, everyone knows that not every patient can have oncoplastic breast surgery, not every patient has a reconstruction. So you have to be able to roll your sleeves up, get your hands dirty, be part of the unit, do the clinical work, the clinics, the outpatient clinic, the follow-up clinics, take part in the audits, be part of the research projects, be part of the publications, and then comes surgery. So surgery is one of the aspects of the whole fellowship. It's not the aspect of the fellowship. Taking part in the MDTs, learning the decision process, because everyone wants to rock up to theater and operate, but no one wants to go and attend the joint oncoplastic clinic. So these are things that they need to understand before they apply. And of course, there's a lot of competition because webinars have suddenly made the world realize that there is a bigger world out there, and certain centers are accepting people and they have certain merits. So there are a lot of applications. So there is also build up your CV. What I would say is work on your CV. Like Linda said, it's easy. You need to publish. You need to show us your desire to do something in breast surgery. It's not like, oh, I didn't become a GI surgeon, so let me become a breast surgeon. Because certain people apply to you and all their publications are hepatobiliary surgery, but then they suddenly wake up one day and say, I want to be a breast surgeon. And it doesn't work that way. So you have to show a definite interest in breast surgery before we can accept you, because we also want, our reputation is also at stake when you go out and say you trained at guys. We expect that level like you did, Yazan. You've done well for yourself. So we want that level of commitment from that, and there has to be something in your CV to reflect that. So I think when you apply to more than one center and see where you want to go and what your expectations are, and outline those expectations, because it's very important. It's not like you're a great guy, so I want to come and work for you, because most of the applications say that. That's not what I'm interested in. I want to know why you want to come and work for me and what is it that you want from me. And when you put it down in black and white, it's much easier for us to identify with your needs and tell you whether specifically we can meet those needs. And if we can't meet them, we would say no.
You sent me 500 miles away from you, Ash. Even a train will not get you to get me to London. I need a flight now. Now, this is not only about UK fellowships. It's not about only European fellowships. There's fellowships elsewhere in the world. There's a huge centers in other parts of Europe. And I know Bahadir, I know many people from Jordan and the Middle East would want to go to Istanbul to do their fellowships because you have high volume, great work there. Any comments about that, Bahadir?
Well, what I can tell you that now Linda would join me as well. We started a new initiation called BRESO. The BRESO is also a European initiation for breast surgeon certification program. So, so far, some centers started to accept some fellows from the regional countries, or also from all over the world. But there are some problems for the time being because of, licensure things and so on. So it depends on where the application comes from. So, for example, for Turkey, for Istanbul, we're accepting fellows from regional countries, but they're coming for minimum 6 months, up to 1 year. So now, for example, yes, we have a fellow from Jordan, from Amman, and he is with us for 1 year, but afterwards, then we will be, because there are people on the waiting list to come to Istanbul. So we're having a network of hospitals in Istanbul, in free hospitals. They're coming and having lectures and, practical training and everything. But the BRESO also provides fellowships in other countries as well, not only in the UK. So there are many units in Sweden, so far I know, in Greece. So it's also a sister, establishment with the European Board of Surgery of Breast Division. So yes, but again, one of the limitations here is the money issue. We cannot provide any salary to these fellows. So it's really difficult for them to come to, let's say, to Istanbul for 1 year, because they have to depend on their own sources. Well, our fellows are getting their salary from their own institution, their home institution. So that's an advantage for them. But this would not be the case for everybody. So and what I can tell here is that they can go to the BRESO website and read more about this.
That's great. And I think many people from the questions, they're confusing qualification with certification with licensing. They're completely different things. Any comments about that, Sue? Because you run one of the most, you have a big master's degree that not only runs in the UK, it's an international degree now. So any comments about that?
Yeah, so I think it's very important to clarify in your mind the acquisition of knowledge versus the acquisition of practical skills. So those two components, as set out in the curriculum, are quite separate. You need to have the background knowledge really before you can benefit the most from going on a fellowship and being able to get the technical skills and the advanced skills. So there are various online programs, but I mean the master's program that we run provides all of the syllabus that's actually stipulated by the ISCP in the UK, but also by ESO in the breast syllabus. And you can learn all that online. Now you can do that at the same time as getting practical competencies. But if you're in a country where there isn't much breast surgery or no specialist units, it's possible to try and acquire that knowledge before coming over to a unit that you can then get your specialist training in, so that you can fully take advantage of your time with whichever unit there is. And in terms of certification, certifying, you have to have fixed number of operations, but not just a fixed number. You have to show competency in them. It's not just that you do 50 or 100 of a certain procedure. You have to be competent to do those. I think Linda's going to mention something about that as well. She's waving. You have to show competency, and you also need to be able to show that you've audited your own outcomes, and that you know what your outcomes are. So again, you can do the numbers. You need to be competent, but you also need to know what your own results are as well. So it's all those factors, I'd say. But Linda was waving, so she might
Linda, do you want to say something?
Yeah, so I saw quite a few people asking whether or not having these exams, or indeed the UAE master's degree, is the same as getting registration for practice in a particular country or in Europe. They're not. These exams at the moment have value in that they show that you have passed an exam, and therefore to pass that exam you will have a certain level of knowledge, but they do not certify you to work within Europe or an individual country within Europe. It's important people are aware of that, because I know that some people take these exams thinking that it's like getting a GMC for working in the UK. So there are different and very confusing regulations in different countries across the world. Every country has its own system of certification to give you permission to work professionally within a country. This is not what these exams are at the moment. We would like them to be. We would like them to have that value, and we're working towards that. But at the moment, all they do is show that you have a certain level of expertise and knowledge, which we think is of value.
I think the story might be slightly different with certain parts. With the surgical oncology exam, Ibrahim, isn't there certain societies using the surgical oncology exam as their exit exams now?
Yeah, I had to turn on this. Yes, in regard to this is the particularly interesting story with German Society of Surgical Oncology. In German Society of Surgical Oncology, in collaboration with ESO and UMS, they actually created a curriculum in surgical oncology in Germany, and they established 1-year fellowship. And they do that. That program is their program, their curriculum is very similar to the global curriculum or ESO curriculum. And after their candidates complete rotation, which takes 1 year, then they don't have their own exam, but they actually use our exam. And our exam in surgical oncology is actually exit exam and somehow certification for finalizing their fellowship. Actually, a German fellowship in surgical oncology becomes valid after passing the UMS exam. So far, it is the only one. This is the first case which I know that our exam has some kind of that legal validation. The German candidates, when they apply for the exam, they actually receive 2 diplomas. They receive diploma from UMS, and they receive also diploma without any additional exam from the German Society of Surgical Oncology, which opens them certain possibilities in terms of proving the quality and probably making progress in their careers, things like that. So I think this is the way to go, because before this we had just few candidates in every year coming from Germany, but now there is a waiting list for the exam in German language, and we made an agreement with them so that exam is not offered only for people completed the German fellowship, but it is open to everybody who is going to take the exam in German language. So if you're coming from any country and you prefer to take it in German language, you can take it. But specifically for German people completing that fellowship, that exam is a form of certification and has legal power or legal value.
So it's not the exam on its own, it's the exam with the fellowship. So people that have the exam on its own, they cannot go and work in Germany. So to be clear,
no.
It's the fellowship with the exam that's done by the German Society.
That's right. Only those who completed the fellowship in Germany and pass the exam, they can make some kind of profit from that diploma. But those who did not complete that exam, they cannot. Of course, they will have the diploma, but it means nothing without fellowship.
And there's lots of comments of people asking, I'm from this country, can I sit the exam? And I'm from this country, can I sit the exam? The eligibility criteria for the exams for both the surgical oncology and the breast surgery exam, nationality is not part of them. It's not an exam for nationality, it's an exam for knowledge. So you can sit the exam wherever you come from. Am I correct in saying that, Ibrahim and Linda?
Yeah.
Yes, yeah, there's no limits. The eligibility criteria are on the website, and nationality isn't part of it, although you have to be able to speak English, or in the case of the surgical oncology exam, English, Spanish or German to be able to sit the exam.
Yeah.
And is there any number of retries if you don't pass the exam?
If you fail, you can retake again the following year. If you fail twice, you have to wait 2 years before you can try again. We haven't set any limits to the number of attempts at the moment.
Anything for the surgical oncology one, Ibrahim?
We have almost the same. We are also accepting candidates from all over the world. We have quite a lot of candidates coming from out of European country. And this year we have candidates, of course, from Europe, from Asia, from Middle East, from Africa, and now this year we also had 2 candidates for the first time coming from South America, one from Colombia and another one from Brazil. So this exam is becoming more and more interesting, and so the nationality is not criteria. If somebody thinks that fulfill criteria, is free to apply. eligibility committee will go very in details through their documentation, and if we need something more, we will ask, or if we are happy with send documentation, we will accept him. There are nationality means nothing here.
And there's another comment by some people saying that do Europeans get advantage in those exams? And it's not the case. Those are European exams. So you need to be at the European standards and follow certain European guidelines to be able to pass those exams. It's not because Europeans have an advantage. And if you look at us, half of us are not originally from Europe, but we sat the exam and we examined the exam. So being from certain part of the world is not an advantage or a disadvantage. It's just need to know certain practices. I remember when we were writing some sort of syllabus for the surgical oncology exam. Remember, Sergio, we were talking about this needs to be at certain standards for people to be able to pass, and you need to achieve certain standards to be able to sit that exam. Any comments on that, Sergio?
Oh, just sorry.
That's all right.
Okay.
Yeah.
No. Well, we met lots of people during the past years dealing with this exam, and I think we found a lot of people who were not aware of what this exam really meant, because the exam is a sort of is firstly an assessment of your skills in. I can talk about skills. I can talk about culture. But it's not a professional, it doesn't give you a title or a piece of paper that you can show and you can pretend to be a specialist in that, because that is a matter of local government's rules and regulations and so on. But the great mistake is to invest money in this exam just to not be prepared of what this exam really means. I'm talking about the general surgical exams. I think the breast exam has some slight differences. I think the breast surgeon is more well-oriented than the general surgeon or the surgical oncologist per se. I don't know what Linda thinks about that.
Any comments, Linda?
Linda.
Oh, I think Linda might she had some
please.
Yeah. If I go to, there's a few people asking about the University of East Anglia qualification, and if you want any more information about that, you can just send the email back when you get the follow-up email, and I'll send you more details. But their website is uea.ac.uk. Any comments about that, Sue?
Yes, I think there's a few questions about, does it give you surgical status with the GMC? And no, it doesn't. It's the highest qualification available in oncoplastic breast surgery in the world, but it's not recognised as meaning that you're able to perform breast surgery on your own independently at consultant level. That's what its standard set up. But, you know, in terms of the GMC, you would have to prove various other things to be able to support it. It's part of your evidence base, but on its own, it wouldn't give you that entitlement.
Now, there's certain people asking about fellowships and places in Sweden. If you're looking for something in Sweden, I would suggest to find Andreas Karakatsanis. I don't know if he's online today, Andreas, in Uppsala, and I'm sure Andreas will be able to help with the advice about breast fellowships. And there are some questions about getting in touch with me. Just reply to the emails. I always check the emails. I know I have quite a few hundred emails sometimes. So just reply to the emails and I will direct you. And if somebody is interested in fellowships, for example, in Turkey with Bahadir, I'll send the email to Bahadir. If you're interested in surgical oncology with Ibrahim, I'll send it to Ibrahim. If you're interested in GI or sarcoma surgery and you want me to forward things to Sergio, I'll forward to Sergio. If you want to know more about any of the qualifications with Sue, we'll forward that to Sue. And it's mainly, this is just a network for people to know where to get information from. Now, any other comments from anybody else? Because it's nearly 6:45 now. We've been online for about 1 hour, 45 minutes. Any comments from anybody?
I've shared the link for the Brezo website because I thought that might be helpful, because it's got a list of breast units for training through Europe that Bahadur mentioned, and it's got contacts on there as well. So I have put that in the comments.
That's great. Any other questions from anybody?
I would just like to encourage people to take this exam, because when you pass it and after you finish all this, you will feel different. You will suddenly realize that you change the level of your, I can't say existence, but the level of your knowledge, of the quality you can offer. And because you will invest some time in studying all what we have shown here. And after you accept all this, you will change your practice. You will see that you can do things better.
And there's one question from Jamal Harisha, and I think Jamal is one of the general surgeons and GI surgeons, asking about how to become an examiner for I think the surgical oncology exam. Any comments about that, Ibrahim?
If the gentleman would like to become an examiner, he can send to the UMS office his application, his request, and we will reply him on email what we expect, and by email. And so he should come in touch with us. That's it. That's
great. And if you have problems finding that email, Jamal, apologies. We're not trying to ignore the questions. There's lots of questions online. So if you struggle to find that email, just send me a reply on the info@ibreastgroup.com when you have the follow-up email. It is now 6:50, so we've been online for nearly 2 hours. I cannot thank you enough for taking the time of this evening, for all the speakers and the panelists to be with us. Linda is texting, her internet is not working, so apologies from Linda for not being able to share. And I think Ash is already on his first glass of wine with his guests, so we cannot blame him for not being with us. So for people in South America and North America, have a lovely day. For people in Europe, have a lovely evening. And for people in the Middle East and the subcontinent, have a good night. Many thanks, everybody, for being here tonight.
Thank you.
Thank you. Bye.
Bye.